This month on the Living Ladies podcast, a review of the questions you asked. Good morning, Dr. Bissoondatt.
Hi, good morning, Amanda. How are you today?
I'm fine. How are you?
I'm fine too.
We're actually in the month of June. Half of the year has gone, and you've done a lot of recording in terms of giving out information for the past couple of months. We've had cervical cancer awareness. We've done sexually transmitted diseases. We've done endometriosis. We've done COVID-19 education and also C-section awareness as well. So out of all of those questions came out, more so for C-section though. And we would like today to ask you a few questions, answer some of those questions for us.
Okay, no problem.
Okay. The first question that was asked was, once your fallopian tubes have been tied, can the procedure be reversed?
Yes, this can be reversed. However, the success is really only about 25 to 30%. And the success also depends on the length of the tube remaining because the egg and the sperm gets fertilized in the tube. So if you have a very short tube, your success rates are much lower than if you have a longer tube. In the past, when we tied tubes, we would take off a small piece of the tube so that in the future, again, you can possibly reverse it by reconnecting the tubes. In the last few years, some recent studies showed that removing the entire tube at the time of what we call tubal ligation or tying of the tubes decreases your chances of ovarian cancer. And therefore, a lot of gynecologists and obstetricians are now removing most of the tube rather than taking out a small piece. Therefore, because of that now, your chances of reversal would be much less than 25 to 30% chance.
Coming out of C-section, someone asked, how long does a woman have to wait to get pregnant again after having a C-section?
Okay, generally we advise waiting for 2 years, especially if somebody wants to try for vaginal delivery. The abbreviation we use after cesarean is VBAC, vaginal birth after cesarean. Now, waiting the 2 years is usually to decrease the risk of what we call scar rupture or the womb opening up in labor. Now, this could actually happen before labor and in labor as well. The highest chance is in labor while you're having contractions. However, if you want another cesarean section, then you may not have to wait 2 years, but it's reasonable to go after 1 year. And the reason for this is healing generally takes between 9 to 12 months for the strength of the healing tissue. So by 1 year, you are fine to go ahead and try for another pregnancy if you want to go for another cesarean section. But if you want to try for a normal delivery, then we usually advise 2 years.
Coming out of C-section also, what are the possible outcomes of the healing process where the incision site is concerned?
Okay, so you have your immediate complications and your more long-term complications. So an immediate complication is this incision could get infected. And to prevent this, we usually give antibiotics. The cut could also open up, and again, infections contribute to why a scar could open. Opening of the cut can also occur depending on the type of stitch that is used. Some obstetricians prefer to use dissolvable stitches, and infections actually help the stitch dissolving more quickly. So it can open up with a dissolvable stitch. With the stitches that have to be removed, obviously the chances of it opening up is a little less. However, the risk is still small using a dissolvable stitch. Also, when obviously your skin is cut, you cut through blood vessels. So what can happen is you can have little bits of bleeding under the skin, and this causes a blood clot or hematoma, and this leads to an hardening under the cut. Now, that type of hardening is usually immediate, and it takes about 3 to 4 months to soften up, and it can soften up. Sometimes, if it's very big, it could actually burst, and women may see like a clearish to yellow fluid coming through a spot. So it's not an infection, but is what we call serous fluid coming out because a clot is dissolving. Another kind of intermediate risk would be numbing of the cut. So again, when you cut the skin, you are actually cutting nerves. So when you cut a nerve, you damage a nerve. So some women remain with the cut being numb, totally numb. And others will get it where it has an altered sensation, meaning you touch it, you can feel it, but it doesn't feel like the surrounding tissues. And that's pretty normal for most cuts. Also, more long-term effects is with after 3 months, a scar can be flat and perfectly in line with the rest of the skin. You can also get something called a hypertrophic scar. Now, and also a keloid. The difference between a hypertrophic scar and a keloid is that keloid is an abnormal growth where it's actually beyond where the cut was made. So it's very, very thick. A hypertrophic scar, it just feels a little lumpy and it's not flat. Some people are prone to getting keloids, and unfortunately, we can try to minimize that risk. Sometimes we use medications such as steroids to do that. So somebody who is known to get keloids, you try to prevent it if you know that in advance. So those are the risks.
Okay. So is it safe to say that if a person develops a keloid or scarring, that it could be treated at a later point in time?
Yes. So a hypertrophic scar can be removed and a fresh new scar is formed. And it's the same with keloids. The difference with a keloid is once you are prone to getting keloids, you're prone to developing it again. So if it wasn't known that you can develop keloids and you find out after a cesarean, you can have the keloid removed and given medical treatment to try and prevent that keloid reforming again. Also, women who have repeat cesarean sections or any type of operation on the tummy using the same scar, generally it can be removed at the second operation. And this is what I tend to do. I remove the previous scar so you can get a full scar. Not everybody do that, and some people will try to go through the previous scar, but obviously you'll have two areas of healing. And sometimes it's difficult to go through the exact same spot, so you may have two lines forming.
Also coming out of C-section awareness, how soon does your menstrual cycle go back to normal after having a C-section?
Okay, right. So that is actually very variable. The earliest that it can come back is literally like a normal period, 4 weeks after delivery. And it doesn't matter whether you have a cesarean or a normal delivery, it can come back after 4 weeks. And it really depends on how long someone is breastfeeding for, because breastfeeding causes the hormone prolactin. Prolactin in itself causes your eggs to not come out very quickly. So someone who is totally breastfeeding, their periods would actually be more delayed than somebody who breastfeeds for 1 week or a few days and have problems with that. That person period will come back a little earlier. It also depends on medical conditions previous to getting pregnant and if you develop one after pregnancy. So some of those conditions would be especially polycystic ovarian syndrome. Now, polycystic ovarian syndrome is something that's triggered by weight gain. And as we all know, we put on weight in pregnancy, and the average weight gain is about 25 to 30 pounds. So if you don't lose this weight after you have a baby, you can actually develop polycystic ovarian syndrome. And this prevents women from having regular periods. So you start skipping periods. The person will notice this as having a period every 3, 4 months, sometimes 6 months. So that's one condition. Also, thyroid issues. So generally, a low thyroid can make you skip periods as well. And some women have this thing called hyperprolactinemia, where they have excessively high levels of prolactin that has nothing to do with the pregnancy. They again will also skip, their period will come back after a long time. I personally won't be worried if you didn't have a period for about 1 year, especially if you're breastfeeding, because it could literally be due to breastfeeding only. However, if somebody didn't breastfeed or stopped after, say, 1 month and they didn't have a period for 6 months, I would start investigating that patient because it may mean that something has developed during that time that has prevented them from starting back normal periods.
Our final question comes out of COVID-19. Someone
Okay.
asked, what advice would you give to a pregnant frontline essential worker in this COVID-19 time?
Okay, so as we know, we don't have all the evidence because this is such a new condition. We just have to go based on what information we have currently. As we had discussed previously, pregnant women are no more at risk of getting COVID 19 unless you have other comorbidities such as diabetes, heart problems, lung problems. So, low risk patients are those considered to be children and healthy adults. So, if you're a healthy pregnant woman, you are no more likely to actually develop COVID 19. But the data so far has been shown that if a pregnant woman gets a respiratory infection, especially in the third trimester, then she is more likely to be seriously ill. And data from the United Kingdom shows that most of the admissions for pregnant women were in the third trimester or after 28 weeks. An average was around 34 weeks. Therefore, we were advising women not to be face to face with people who have COVID 19 after 28 weeks gestation. And also, we need to do a risk assessment for all pregnant frontline workers, which means your actual medical history, also your working environment. So, are you working in closed areas, air conditioned areas, or are you outside? And then the role that that person plays at their job. So again, if you are at a telephone and you are not near somebody, then you are more low risk and you can continue beyond 28 weeks. So generally, employers are obligated to protect their pregnant workers, limit their contact with COVID positive patients or suspected COVID patients. Um, we don't advise working with them after 28 weeks of gestation. And again, if you think this person is over 28 weeks and you want to continue working, you do your risk assessment. That person can continue to work, but try alternative duties such as remote triage, maybe telephone consultations, more administrative or governance roles. And if you decide to continue working, make sure you use your protective gear, use your mask, cover up appropriately with long sleeve and long pants, hand washing and distancing.
Thank you. Is there anything that you would like to say directly to our audience in terms of the questions being asked, or anything that you may want to reiterate from the past, which you have already recorded?
A lot of questions and comments came out of patients asking about if you have to have a cesarean after your first cesarean. And that is not 100% true because it depends on the reason you had the first cesarean section. Usually, it is recommended if someone has a small pelvis, and we generally call that condition cephalopelvic disproportion. Cephal means head, and pelvis is, well, your bones. So this is manifest as what we call failure to progress in labor. So someone is in labor for hours and hours and they don't dilate. That is a maybe because of cephalopelvic disproportion. And even some women reach to fully dilated and the baby just does not come down in the pelvis. So they try pushing for more than an hour and the baby head remains high. So that could be true disproportion, and therefore for that condition, someone should definitely have a repeat cesarean section. Also, previous removal of fibroids, depending on where that fibroid was. If it was high up in the womb, and if during the procedure the womb was cut very close to the lining, then that woman should have a cesarean section again. Also, something called a classical cesarean section, which is not very common at all. A classical cesarean means when the womb cut is a vertical cut. We're not talking about the skin cut, but the cut on top of the womb. It isn't used very commonly anymore, but an instance where that has to be done is if a baby is in transverse lie. So instead of the baby lying head down and bottom up, it's across the mother's tummy. So for that case, to get the baby out, you have to do what is called a classical cesarean section. Also, reasons for trying for a normal delivery after the first could be if your first cesarean was a breech presentation or any other abnormal presentation, such as where the head is not down first. Also, what we call fetal position. So the head is down but not facing backwards, or that the face is towards the mom's bum. The face is looking to the side or even looking up. So that's called abnormal position. Those instances, the baby's head diameter is actually bigger than when looking down. And it could be even 2 centimeters more than when the baby's looking down. And then that head position is too big for that mother. Therefore, they could try for a normal delivery after. Fetal distress, as everybody knows, with some reasons we don't always know, and someone could try for a normal delivery if their first cesarean was due to fetal distress. Some other reasons could be a placental abruption, or where the placenta separates from the mother's womb. That is not a recurring condition, so again the mother could try for a normal delivery. Also, something called meconium in labor, where the baby does a poo inside. And if the baby doesn't do a poo the second time around, the mother could have a normal delivery. And one other one, which is not always common, but the cord holding a baby back from coming down. I've seen this a few times where a woman has a normal delivery in her first pregnancy, and the second one she's in labor for longer. And we don't want to do a cesarean, but we had to end up doing it. And when we went inside, what we saw is that the cord was tangled around the baby. So the baby couldn't come down. The cord was holding the baby back. And again, that's not a recurring condition. So a woman could try for a normal delivery after that. So you must always find out from your obstetrician or doctor what was the reason for the cesarean section the first time, and whether you can try for a normal delivery again.
Thank you for clarifying that myth. If your first birth was a C-section, the rest will be two. Okay, so that myth was clarified. As doctor said, it's based on what was the cause for the first C-section. So doctor, we've been having a lot of feedback on Facebook based on all the recordings and information you've put out there. And questions have been coming in comments, and we appreciate them a whole lot. Would you advise those who are listening or following on the best way possible in terms of contacting you, or what would you say is the best way for someone to contact you?
Okay, so I really thoroughly appreciate all the feedback that I've been getting on Facebook. However, as we know, everyone is unique. Everyone has to be tapered into their own scenario. And it's not really the best practice for me to give advice on Facebook, because everyone is an individual. So what I advise is it's better that you book an appointment so that I could tailor the consultation to help that individual. We are also thinking of creating a Facebook page separate, where comments on everything can be answered, and this is not public so that everyone doesn't see your information. We'll do a page alone for that.
Yes. Within that Facebook group, we will be sharing the video recording of these audio. So look forward to that, which is coming. And please continue to like, share, and subscribe so that more information could be given towards your health, women's health. So, doctor, how can someone get in contact with your office?
So I work at Southern Medical, and you can call me by direct numbers are 290-1249, and my assistant Natalie, it's 394-7528.
Thank you, doctor, again.
You're welcome, and nice talking to you again.